Good evening and thank you to everyone for joining us today. On behalf of Jagsonpal Pharmaceuticals, I welcome you all to this webinar, Filling the Lacunae theme, Learning the Continuous Process. This webinar is initiated by Lalita Memorial Hospital, Rewari, in association with Rewari Obs Gyn Society, supported by Indian Fertility Society Haryana chapter, with Jagsonpal as an academic partner, the makers of Divagest, Maintane, and Divatrone. We would like to present Divatrone 10 milligram tablets, fully indigenized, dydrogesterone, the only dydrogesterones having 36 months of shelf life. We would also like to present our natural micronized progesterone range as Divagest and hydroxyprogesterone Maintane. A warm and hearty welcome to all the esteemed faculties and attendees. Dear attendees, if you have any questions, suggestions, please post it in the chat box. And please note this webinar is streaming live on Facebook. The link is already being shared in the chat bot. To refer this webinar in future, please visit our YouTube channel, Jagsonpal Medical Insights. For this webinar, I invite Dr. Seema Mittal, Director, Lalita Memorial Hospital and Infertility Center, Rewari. She is past President, Rewari Obs Gyn Society, Treasurer, Haryana chapter of Indian Fertility Society. Ma'am, please kindly initiate this session.
Thank you, Amitji. Hello and welcome everyone. At the outset, we appreciate your presence and your valuable time that you all are with us. Hope the talks are beneficial to all of us. I'm Dr. Seema Mittal. We have Infertility Center in Rewari, Haryana. And over almost 3 decades of infertility practice, it has become a passion for me. But friends, learning is a continuous process and we can't be master of every field. So here we have the most wonderful speakers like Dr. Bela, the woman of substance, the best teaching etiquettes, and the master of masters, Dr. Ashok Kumar, who would be talking on obstetrics, cholestasis in obstetric and pregnancy. COVID has done one good wonder to us, that we can all meet on this platform and share the views, and it's such a bonus and bonanza for us to know the lacunae and the weaknesses that we have to cover up. So I'm sure this is going to benefit each and everyone. We would have questions and answers in the end so that it doesn't interrupt the session and doesn't distract our speakers. So I will now request Dr. Alka Yadav, our charming president of Rewari Obs Gyn Society, who has that taste for all academic activities, and she's always yes to all our requests, to invite none other than our dynamic Dr. Bela Bhatt. Dr. Alka Yadav is a very senior consultant. She's the senior most, I would say, in Narnol, and she's always helping everybody, not in Narnol, but Rewari as well. So over to you, Dr. Alka, to invite speaker of the day, Dr. Bela Bhatt.
Good evening, everybody. Thank you, Dr. Seema, for making me a part of this webinar. Actually, I always like academic activities. And as truly said, because of COVID, we have been able to meet academicians from any corner of the country, or this thing international, also on international webinars. So we have been able to meet, and it really feels good to satisfy your hunger for all these academic activities. So it's a really good thing. I'll take, not taking much time, I'm going to invite Dr. Bela Bhatt for the first talk on first trimester scanning. Dr. Bela is a OB-GYN fetal medicine consultant at Dr. Bela's Women Hospital, Andheri, Mumbai, and she's also a fetal medicine consultant at Dr. Baba Saheb Ambedkar Memorial Central Railway Hospital in Mumbai. She is a FMF certified sonologist from UK, and also certified sonologist for FMF from for nuchal scanning. She is a life member of the Society for Fetal Medicine and joint secretary for AFG Mumbai. She is also medical managing council member of Indian Society for Prenatal Anomalies. Then CS Dawn first prize has been received by her in AICOG Bhubaneswar 2018. She is also the first prize winner of FOGSI has Talent National Competition. She is national convener for FOGSI Superstar Competition 2019-20. And presently she is chairperson for FOGSI Imaging Science Committee. So I invite upon Dr. Bela to please start the session with her talk.
Thank you so much, Dr. Alka Yadav. At the outset, I would like to thank that henceforth I think you can just introduce me as one of the associate member of Rewari Society, because now we are like family and I'm part of your society. Have come so many times and we have
Really welcome, ma'am. Thank you so much for honoring us with this.
So,
Really,
so I feel like family, and I'm extremely thankful to both Dr. Alka Yadav and Dr. Seema Mittal, who is a dear friend of mine. And we have been now like online, we have met so many times since 2020. So thanks for having me here today. And it's my pleasure always to, interact with you all from Rewari Society. I'm very happy, first of all, to know that Rewari Obs Society members and IFS Haryana, you are putting up such good webinars, and everybody is genuinely interested in knowing the subject. And therefore, the discussion is always so lively and so good, and the interaction is so good. So this time the request was to discuss about the first trimester scan, or as we call as nuchal scan or NT scan. Now, first of all, I would like to say that initially, when we learned in our residency, the traditional first trimester was from the first week to the 12th week of pregnancy. But now, for all practical purpose, our functional first trimester is from beginning of pregnancy till 14 weeks or 13 weeks, 6 days. Why so? Because typically the nuchal scan or NT scan is done between 11 to 13 weeks, 6 days, or when the CRL is between 45 to 84. Now, once upon a time, when in 1992, Nicolaides started with this nuchal scan and started talking about it to the world, it was just meant for aneuploidy screening. But now we know that with the advent of technology, better resolution machine, better training, better skilled sonologists, we get so much more information from these 11 to 13 week 6 day scan or nuchal scan. And what is all that? Number one, accurate dating. We know that the precise CRL that we take at nuchal scan gives us accurate dating, and we'll just discuss that. Then second thing is aneuploidy risk, structure anomaly screening, prediction of preeclampsia and fetal growth restriction, and also it has a very important role in multiple gestation. Now, because we gather so much information from this, Nicolaides proposed this inversion of pyramid of antenatal care, because initially, when we used to learn in our residency, we learned that there should be less visits in the first trimester, maybe one visit in the first trimester, then one at maybe 16 weeks, and then from 20 weeks onwards, monthly, and then from 30 weeks onwards, 15 days. So what was the aim of this? The aim was just to react to the complications in the later half of pregnancy after they develop. But now the basic concept is that we should widen this early 12 weeks pyramid, and we should try and kind of predict early some of the complications of pregnancy and try and act to prevent them or delay them, so that we do not get those complications in the second half of pregnancy. So that's the major difference in the antenatal care that we give. And the nuchal scan or the first trimester scan has a major role to play as far as this basic inversion of pyramid is concerned, because based on this information, we'll be able to segregate our patients into low risk and high risk category, and we'll be able to give individualized prenatal care as per the information that we get out of this scan, which I'm going to discuss throughout this talk. Now, the first and the foremost and the most important aspect of nuchal scan is dating. Yes, because the dating that we do from the precise CRL at nuchal scan will help in growth monitoring and timing of delivery. If your initial dating is not proper, entire growth monitoring is going to go haywire. Maybe we can have a talk on fetal growth restriction, and I can give a whole talk on importance of dating. Because if your dating is not correct, you cannot pick up FGR, you cannot manage them well. So it is And in 30 to 40% case, I'm sure everybody sitting here must agree that patients either are the LMP is wrong or they have irregular cycles. So the dating is not perfect based on the history. But remember one thing, even in the nuchal scan, it's extremely important that the CRL is taken in a standard way. And what do I mean by standard way? The fetus has to be in the mid-set position with neutral head, with the whole fetus occupying almost 75 to 80% of your screen, and both the crown and rump has to be seen clearly to be able to measure the CRL. And if the CRL is taken in such manner, then the dating that you get out of it, the expected date of delivery that you get out of this is the final one, which does not change throughout the pregnancy. Further, we'll just monitor the growth based on that. So one thing is very important, that whenever you have a look at your nuchal scan, have a look at the images as well. And if you do not have a standard image, then that nuchal scan should not be considered valid, right? Now, why there is so much importance in taking precisely, has this study which shows that if there is a variation in CRL by even 2 millimeters at 11 to 13 weeks, you can see so much difference in the centiles at 20 weeks and in the second and third trimester. Towards the end of third trimester, you will see 12 or 8 centile difference. And so obviously your fetal growth restriction diagnosis management, everything is going to be wrong. So it's important not to make even 2 millimeters or 1 millimeters difference in the CRL. So that was one very important aspect. Now, the nuchal scan initiated, as I told you before, mainly for aneuploidy screening, because we used to look at the 4 important soft markers: nuchal translucency, nasal bone, ductus venosus, and tricuspid flow, when the CRL is between 45 to 84. That has to be remembered. If it is 85 or 86 also, we can't take it. If it is 45 CR, 44 CRL, then also we can't do it. So the CRL has to be between these two, because all the studies have been carried out based on this. And it is never just a nuchal scan. Usually, we always combine it with a double marker to improve sensitivity, which we'll learn through the talk. Now, first, we should understand what is nuchal scan as far as aneuploidy screening is concerned. So, as the name suggests, it's a screening test, right? And what is a screening test? Screening test is an indirect test, and it just helps us to segregate high-risk population from low-risk population, and it is not a diagnostic test. Now, why we should all remember this? Because we must counsel the patient before any screening. Pre-test and post-test, both counseling is extremely important. And pre-test counseling, you need to tell the patient that this is not a diagnostic test, because suppose at the end of test, the result is low risk, and you tell the patient that you are this is a low risk report. Patient will perceive it as there is no trisomy 21, 18, 13. No, even if the result is 1 in 2000, that one Down syndrome is sitting in that, because this is a screening test and not a diagnostic test. So if that patient's baby turns out to be Down syndrome, patient will tell you, you told me there is no Down syndrome. How come my baby has got this? So always counsel beforehand that this is just a screening test, not a diagnostic test. So we can miss out some of the fetuses. And those who turn out to be high-risk population based on this screening test are then offered invasive tests like CVS or chorion villus sampling and amniocentesis, and are offered diagnostic tests to reach to the conclusion whether the baby is having any kind of aneuploidy. Now remember, whenever you are doing any screening test, there is always one a priori risk or baseline risk, which is based on the age of the mother. And as the maternal age increases, this baseline risk of trisomy 21, 18, 13 increases. And therefore, we see that when the maternal age is more than 35, the chances of Down syndrome increases. But again, remember, we can't take just age as this screening tool, because then we'll miss 70% of aneuploidy trisomy 21 that occurs in less than 35 years of the age. So screening is for all. Remember that. Screening is for all. Now let's have a look at the different markers. So I'll start with the first, nuchal translucency. And as we all know, nuchal translucency is nothing but a collection of fluid behind the neck of the fetus, and the size of it is important. So when you are taking a nuchal translucency, again, there has to be a standard image to measure nuchal translucency. So there has to be, the fetus has to be in mid-set position, neutral position. The head should neither be too much flexed or too much hyperextended. There has to be a pocket of lichen between the chin and the chest. The square palate should be seen, nasal tip, skin over the nasal bone, and the thin nuchal membrane and the widest nuchal translucency is what you should be measuring. So when we measure the nuchal translucency, along with your nasal bone, which is shown here by the equal sign, this is the nasal bone, this is skin above it, which makes the equal sign. And this is the nuchal translucency, and we'll measure the widest measurement of nuchal translucency. In the same image, now, as I said, with the improvement in the skill and the machines, we get so much more information. We can see the diencephalon, we can see the intracranial translucency, which is a surrogate marker for picking up some of the open spina bifida. And so all this information is gathered in the same image that we take for nuchal translucency and nasal bone. So two markers we can see. Again, remember, nuchal translucency is a function of CRL. So if the CRL has not been taken in a standard manner, then also your calculation for aneuploidy goes wrong. Or if the nuchal translucency is not taken in a standard image, then also your calculation for trisomy 21 goes wrong. So if we are doing on our own, we all know that this is what is required, but quality control is something which is extremely important. If we are doing, we should try and get this. And that is possible with the FMF UK certification, which is which can be done online. And if you are not doing it on your own, and if you are prescribing it, sending it to a sonologist, when the patient comes back, have a look at the images. And if they are not standard, I think that nuchal scan should not be used for calculation for trisomy 21, because that will be completely wrong. And I'm sure every one of you still get such images as nuchal scan reports. This is how the CRL has been taken. Is this correct? No, this is not how we should take a CRL. This is how the NT has been taken. Is this correct? No, this is completely wrong way. So what is important is quality control in nuchal scan. It's important that we get a nuchal scan done by a trained sonologist who gives you standard images of CRL, NT, NB. Then only your risk calculation is proper. Otherwise, put aside that nuchal scan, because we are wasting the money of patient on that nuchal scan if it is not done properly. And therefore, we all must aim to do this FMF UK certification, which is available online, and get our nuchal scan certification, do it in a standard way. Now, again, when the report of nuchal scan comes, one thing which is sometimes mentioned in the report is high NT or nuchal translucency. Now, what is high NT? High NT means when the nuchal translucency is more than 95th centile for that particular CRL. As I said, nuchal translucency is a function of CRL. So for a particular CRL, when the nuchal translucency is more than 95th centile, we call it a high NT. Again, here the counseling becomes very important. The moment you will tell patient that the nuchal translucency is high and their baby is at higher risk for aneuploidies, the patient will go and terminate the pregnancy. So here, first of all, we have to understand what does the word high NT or nuchal translucency means. Remember that even when the nuchal translucency is between 95th and 99th centile, 93% fetuses are going to be normal or euploid. Only 7% are affected. And when the nuchal translucency is even more than 99 centile, which is, if by cutoff you see more than 3.5 millimeters, 70% fetuses are still normal. Only 30% are affected. So counseling patient is important, that we need to try and rule out the causes of high NT, but termination is not the answer, because then you'll be terminating this 93% or 70% fetuses which are normal. So we must investigate for the cause. And first thing that you want to rule out, that patient would be in the high risk for aneuploidy. So do a diagnostic test, either CVS then or amniocentesis at 16 weeks, and rule out chromosomal aneuploidies. Or there are other reasons also for high NT. It's not always that aneuploidy which is giving rise to nuchal translucency. There can be very, very common is the cardiac anomaly. Other structure anomalies like mediastinal mass compression, diaphragmatic hernia, genetic syndrome, skeletal dysplasia, torch infection, anemia. So one by one, we must rule out these causes. And if these all are ruled out, as I said, the baby would be normal. So don't jump and explain to the patient that this is high risk, then the patient will terminate. So this kind of termination should not happen because of lack of counseling. And when we are counseling also, rather than using the word high risk, we must use the word high probability, because then the patient will not be alarmed. You can, because even when the risk is high, like 1 in 150, it means that out with such reports, one fetus out of 150 would be affected by trisomy 21 or 18 or 13. Rest 149 will be normal. So that's how we are supposed to counsel the patient. That's extremely important when we are counseling this patient post-test also. So I'll keep on telling that pre-test and post-test counseling, we have to take out time, or you have to have somebody who's properly, educated about how to counsel, should be there to counsel the patients before the test and after the test. Otherwise, you'll face problem at the end of the test or at the end of pregnancy. Now, that was about NT and NB. Now, doctors, there are two more markers which we use whenever we find that you can use it when the nuchal translucency is in the 95th to 99th centile. And these markers are ductus venosus and tricuspid flow. So now in ductus venosus, normal waveform is this triphasic. And in this, these two big waves are not which are bothering me. What is important is a small wave here. If you can see, this is the A wave. This has to be possible. It's a small wave only by atrial contraction, but that has to be positive. If it is reversed like this, reversal of A wave, that is what is going to cause worry. And it is associated in 65% of trisomy 21, but again in 3% of euploid fetuses, you can see that. And more importantly, whenever there is a reversal of A wave, I'll go and have a look at the heart very closely, even at 12 weeks, because there are very high chances that there can be cardiac defects, or it can also be one of the marker for fetal death, which can occur soon in such babies. So whenever you get this, be very, very cautious and have a look at the structures and especially the heart of the baby. Now, another fourth marker is tricuspid flow in the nuchal scan. Again, where we look for the tricuspid regurgitation, and if it is present, it can be seen in 55% of trisomy 21. But again, do not forget, it can be there in 1% of euploid fetuses also. So we always have a look at the entire picture. What was the a priori raise? What are the other markers? How is the nuchal translucency? How is the nasal bone? And then we combine all the markers together and put it in the calculation and find out the risk and counsel the patient. Again, as I said about ductus venosus, the chances of cardiac defects would increase if you find that there is a tricuspid regurgitation. So both ductus and tricuspid are also markers for cardiac defects. We always have close look at the structures, but with these two markers, especially look at the heart also. Now, one simple marker is always a part of risk calculation. We always include this, that is normal, that is the heart rate of the baby. Now, why is it important? Because in trisomy 21, 13, you will find tachycardia, whereas in trisomy 18 and triploidy, you will find bradycardia. Now, if you look at your double marker, that is beta HCG in Pepe, in trisomy 13 and 18, you'll find that both beta-HCG and Pepe are on lower side, right? But if you look at the heart rate in trisomy 13, there'll be tachycardia, whereas in trisomy 18, there'll be bradycardia. So it will help to differentiate between these two conditions based on heart rate, and therefore the FMFUK software also takes always heart rate into account. Now, this is a very, very important slide which tells you about the sensitivity and specificity. So as I said, maternal age alone has only 30% sensitivity. When you add double marker, only double marker has just 60% sensitivity. Only nuchal scan, nuchal translucency has just 80% sensitivity to pick up trisomy 21 with 5% false positive rate. But look at the magic. When you combine the nuchal translucency along with double marker, the sensitivity improves to as high as 85 to 90% with 5% false positive rate. And therefore, this is one of the best screening tests for trisomy 21. It's also done early in the pregnancy at 12 weeks. So the results are out earlier. The patient needs any diagnostic test that can be offered earlier. So that's what is extremely, extremely important. As you add the markers, the sensitivity further increases with reducing false positive rate. But again, remember, when you're counseling the patient, remember that if the nuchal, this combined test is done at around 11 weeks, the sensitivity is highest, 92%. But if it is done at 12 weeks, the sensitivity is around 85%. And if it is done at 13 weeks, it's around 80%. So it also depends on weeks. And generally, we prefer to do it around 12 weeks because we also want to have a look at the structures of the fetus. This also has to be kept into mind. Now, having known about all these markers and all, ultimately, you have to look at the nuchal scan report or the combined risk report when it comes to you in your hand. So what do? You don't have to go and just look at the risk. We start from the page 1, look at the date of birth, so age of mother. Based on that, that's going to decide your a priori risk. So you check that first. Look at the LMP, whether patient is sure of it, because as I said, dating is very, very important. Then we look at the CRL. Then we look at the nuchal translucency. Then we look at the centiles of both. CRL is at 58 centile. Nuchal translucency for that CRL is at around 58 centile. So I know that nuchal translucency is not very high. Then I go and look at the biochemistry, that is MOMs. We always look at the MOMs of beta-HCG and Pepe. So here I can see they are almost okay. Look at the uterine artery PI, MOM, slightly on higher side, but not very high. And then I finally go and have a look at the trisomy 21, 18, 13 risk calculation, because now I have in mind that even the nuchal translucency is low risk, even the biochemistry is low risk. So that's the reason this result has come as low risk. And I know for sure that this is a combined risk because it is mentioned here that all this result is based on the sonological markers as well as beta-HCG and Pepe. So my sensitivity of this test is 85 to 90%. Okay. So always have a look at all these things in your nuchal scan report and not just the last page. And as I said, I'll keep on hammering. Please have a look at that. Look at the images. If they are not standard, put that report aside because that's not going to help in proper risk calculation of aneuploidy. I just give example of one case here. This was a 41 years old female who had conceived with the IVF with donor egg, was sent to me with high risk for trisomy 21, referred for invasive test. When I looked at the report of nuchal scan that the patient was carrying here, look at the background risk. What is it? 1 in 39. What does that mean? That they have taken the age of the mother here as and that's the reason the background risk is high. Therefore, even after improvement, the adjusted risk is still high, and therefore patient was sent for invasive test. Now, ideally, I wish this was one-to-one communication, that this would have been better. So always remember that when there is IVF pregnancy with donor's egg, we have to put donor's age here, not patient's age. So donor's age was just 21 years. So the baseline risk only would be low. Look at the baseline risk, so low, 1 in 1100. And therefore the adjusted risk is also low. There was no need of invasive test. Previously, they had taken 41 as the a priori risk, and therefore the risk was high. and therefore the final risk was high. But if we take the correct donor's age, look at the correction, this patient did not require any invasive test. So just one small thing, age correction, is so important. So every small thing matters. It's not just a good nuchal scan or a good lab that you are sending your biochemistry to, but it is the age and every small factor that you have to fill in the form when you send it for the biochemistry: age, race, height, weight, the history, whether IVF conception, multiple pregnancy, everything matters. So fill the form also properly when you are sending it to biochemical lab, because otherwise even the biochemical risk is going to be wrong. So knowledge becomes power only when we put into the use. So I'm so happy that Dr. Seema and Dr. Alka and everybody is so keen to, kind of putting such subjects for discussion so that we learn. But then we have to make use of this into our practice, in day-to-day practice, and then only it's going to be useful to us. So that was one important arm of nuchal scan, that is aneuploidy risk calculation. The second important arm is anomaly detection of anti-scan. We know that the incidence of anomaly, congenital anomalies, to the tune of almost 2 to 3 per 100, which is higher than that of Down syndrome. And with improvement in the skill of sonologists and better machines, we are able to pick up almost 50 to 60% of anomalies at 3 months. And therefore, we must not miss some always detectable. And these are acrania, lobar holoprosencephaly, encephalocele, anencephaly, body stack anomaly, limb reduction anomaly, exomphilos, gastrocystis, megacystis. These are not just the names. I'll show all the cases. There are many more than this anomalies that were picked up at our center. I'll just show a few of them. This was a case, all these are picked up at nuchal scan. This is a case of holoprosencephaly, as we can see here, a monoventricle with cyclopia, and obviously patient terminated this, and this turned out to be trisomy 13. So a gross anomaly which should never be missed at 12 weeks scan. This is a very interesting case where I had a suspicion early on in the pregnancy at 9 weeks itself, and followed up closely at 11 weeks, and was showing an encephalocele, and that was confirmed here as at 11 weeks. And can you see this at 12 weeks? It's obvious encephalocele. It's a major CNS anomaly, as you can see in the video clip. And externally, it may look very small, but it's a gross CNS anomaly. And at 12 weeks, patient wanted to terminate. So see, it's so important that not to miss such gross CNS anomalies. And again, one thing I would like to emphasize here is, whenever there is severe CNS anomaly or there is some lethal anomaly, termination is not just the answer. Always counsel the patient either for antenatal testing by chorion villus sampling or amniocentesis to rule out genetic cause, or if the patient is not ready for that, you can always send the fetal tissue to the genetic lab for DNA storage. Now, what the genetic lab does, it stores the DNA for 2 years or 3 years at just 2,000 rupees charge. And maybe after 3 months, 4 months, 5 months, you can counsel the patient, get genetic testing done to find out the cause. Why is it important? Because some of the cause may be a recurring cause. So it helps in prognosticating your next pregnancy. So always have a practice. Whenever there's any kind of structural anomaly in any fetus, if you're terminating, contact your genetic lab and at least save the fetal tissue. The DNA will be stored at nominal charges, which will be of great help in future also for patient to find out the cause of it. This was a case of acrania with exencephaly, as you can see very clearly here, and the baby was terminated. A case of acrania with holoprosencephaly, again another case of acrania. These days we don't let this continue till your anomaly scan. All acrania should be picked up at a nuchal scan. This was a case of meningocele with CTEV, as you can see, meningocele, and you'll be able to see CTEV in the in this particular case. So again, picked up at nuchal scan. This was a recent case wherein a diaphragmatic hernia could be picked up at nuchal scan. As you can see here, this is the heart which is completely pushed to right by the stomach here. And if you see in the sagittal section, you can see this is the heart, and behind that, you can see the stomach, which is there in the chest. Here you can see the diaphragm, which there is a defect, and the stomach has climbed up in the thorax. And this is the abdominal circumference, AC, which does not show stomach here because it has gone in the thorax. So again, even diaphragmatic hernia is something which can be picked up at nuchal scan. This was a case of, as I told you, whenever there is high nuchal translucency, this had a very gross high nuchal translucency. Not only that, there was cystic hygroma and there were pleural effusion as well. And this patient had a complex cardiac anomaly, AVSG. As I said, it's not just aneuploidy as a cause. There can be complex cardiac anomalies which can also lead to. So have a look at the heart closely whenever there is high nuchal translucency. This was a gross body stack anomaly which was picked up at nuchal scan. This obviously cannot be missed. And this is a case of axomphilos or omphalocele, as you can see here, which was picked up at nuchal scan. Again, you have to rule out the aneuploidy here, because 20 to 30% cases will be associated with aneuploidy. And if this is ruled out, no other structure anomaly, it can be continued, and then the postnatal surgical correction can be done. This was a case of arthrogryposis where at third, there is fixed flexion deformity at both elbows and knee joint, and we did the genetic testing of this fetal tissue, and it turned out to be one of the autosomal recessive condition in the fetus. And then the parents were tested and they were carrier for this. This was their second pregnancy in which they had such baby. Both babies they had lost because of arthrogryposis. Now this patient had come to me just 10 days back at 3 months, when, because we had the genetic testing done of this fetus in last pregnancy and both parents were also tested. I did her chorion villus sampling at 3 months, and I've sent the placenta for the genetic testing, whether in this third pregnancy, the baby is carrying the same particular mutation or not. So that's the importance of working up on the fetus once you pick it up. This was a case of, again, a generalized subcutaneous edema. This patient was tested to be, and it turned out to be trisomy 21 and was terminated by the patient. Now, the benefits of early anomaly detection is it allows for earlier encephalopathy termination. And we all know as an obstetrician how major role it has to play as far as safety of termination is concerned in the mother's. Termination at 3 months, termination at 5 months draws huge difference. So there is a less risk to mother. It can also protect the privacy of the patient and has cost benefit ratio. Not only that, those patients who are at high risk, those who who want to continue the pregnancy, suppose like I told you, omphalocele patient, if the genetic testing is normal, no other structure anomaly, they want to continue, then it gives time to them to prepare for postnatal surgical treatment and which center they should go for delivery. All that can be decided. The consultation with pediatric surgeon can be done antenatally. So ultimately, it helps the patient a lot. And we are not here just to pick up the anomalies. I'm also happy to tell all my high-risk patients, diabetic patients, patients on anti-epileptic drugs, or the patient who had some past congenital anomaly in the baby, if there is no structure anomaly seen at nuchal scan, at least we can tell that 50 to 60% major anomalies are ruled out at this stage. Of course, it has to be supplemented by second trimester anomaly scan between 18 to 20 weeks. The other advantage of anomaly scan is obese women and women with abdominal scar. At nuchal scan at 3 months, we can do a transvaginal scan and pick up some of the structure anomalies which can't be done at your second trimester scan. So these are the benefits. And we should always remember that only medico-legally, only 50% anomalies are picked up at 3 months. And therefore, we must counsel the patient that we have to do a second trimester anomaly scan at 18 to 20 weeks to be able to pick up other 90% of structural anomalies. Third and important arm of nuchal scan is risk calculation for early preeclampsia and fetal growth restriction. We know it is even more common than structure anomaly, 2 to 8%, 10% possibility of preeclampsia. And we know that we can by early prediction and prevention, we can prevent some of the severe form of preeclampsia, eclampsia, HELP syndrome in the second half of pregnancy. And we know that coming events cast shadows before with what? With some biophysical and some biochemical markers. So biophysical markers are maternal and demographic factors, mean arterial pressure, and uterine artery PI. These are the risk factors. I'm not going into details of it, but we know that there are maternal factors that puts the patient at higher risk for preeclampsia. And then we come to the uterine artery PI, which we always do with nuchal scan. Again, remember, if you are sending it out, nuchal scan, to a sonologist, always ask for a mean uterine artery PI, because that will add a lot for prediction of preeclampsia and fetal growth restriction. So we look at the mean uterine artery PI, and if it is more than 95th centile, it puts the patient at higher risk for preeclampsia. This is a normal uterine artery flow at 3 months, and this is a very less diastolic flow with high uterine artery PI. And if a mean is more than 95th centile, it puts the patient at higher risk. So slight addition of this information in the nuchal scan is going to help your patient a lot in reducing the preeclampsia. Also, we have to combine this uterine artery PI and biophysical markers with some biochemical markers like PEP and PLGF. PLGF is a stronger marker, but I understand cost is also something that matters. So maybe in rural area that is not possible. But PEP is a part of double marker, which I think everywhere in urban and rural areas of India is being done. So if you add, we can see that the sensitivity of prediction of preeclampsia will improve. So when there is a combination of mean arterial pressure and uterine artery PI more than 95th centile and PEP and PLGF less than 0.5, this puts the patient at higher risk for preeclampsia and fetal growth restriction. And this is the biggest SPREE study by FMF UK, which proved the same. Look at the sensitivity. Just maternal demographic factor, that is your history and mean arterial pressure, the sensitivity to pick up preeclampsia is 50%. When you add uterine artery PI, significant improvement, 75% sensitivity. At least do what is least possible. And if you add PEP from your double marker, it improves to 80%. Good enough. We are able to pick up 80% of severe form of preeclampsia, which are land up as eclampsia or HELP syndrome in your medical college. If you want to prevent that, do your nuchal scan with uterine artery PI at 3 months. Start with the low dose aspirin, which I'm coming to. So these biochemical markers are markers of preeclampsia, fetal growth restriction, also markers of abruptio placentae, stillbirth, and preterm delivery. So when we predict, we also want to prevent. We just don't want to predict and tell patient that you are at high risk. We want to give something to prevent. So here is the biggest study again by FMF UK, ESPRESS study, which proved beyond doubt that early prediction before 16 weeks of pregnancy, that is before the second phase of trophoblastic invasion, if you start with low dose aspirin in the dose of 150 milligram, then we are able to prevent preeclampsia. And even FIGO has taken into account this FMF study, and it says that aspirin started between 11 to 14 weeks at 150 milligram at night, continued till 36 weeks, will lead to almost 90% reduction in this early preeclampsia, which is the severe form of preeclampsia leading to all complications. And please do not prescribe low dose aspirin in all pregnant women. Calculate the risk and give only in the high risk patients. So now we know that the nuchal scan, which started with aneuploidy risk calculation, has very important two arms structure anomaly, because that's more common than Down syndrome. Preeclampsia, even more common, 5 to 10%. We have to combine all these and get the information from the nuchal scan, segregate our patients into high risk and low risk category, monitor high risk patients more closely, whereas low risk can be called upon maybe after 1 or 1.5 months. And that's how we can monitor entire pregnancy. We'll be able to prevent so many complications. We'll be able to pick them up early and manage better. Multiple gestation, just one word I want to say here, that there are so many things we look at the nuchal scan. Obviously, the basic aneuploidy structures and preeclampsia, the number of fetuses detected. dating of pregnancy. But the most important aspect in multiple pregnancy or twin pregnancy is chorionicity and amnionicity, right? Because that's going to decide whether it's monochorionic or dichorionic pregnancy is what is going to decide your entire complication and management of pregnancy. And that can be decided based on T sign or lambda sign. Here you can see the lambda sign, which is formed by the placental, the chorion, which is going in between the membranes. This tells me 100% this is a dichorionic pregnancy. And you have to give this image to the patient. Not and whereas if there is the membrane is inserting directly onto the placenta and forming a T, that's telling me that this is 100% a monochorionic pregnancy. Again, you have to give these images to the patient at nuchal scan, because patient may go to some other sonologist who will later on not come to know whether it's monochorionic or dichorionic pregnancy and cannot monitor that pregnancy well, because we know that it is only in monochorionic twins where there is vascular communication, and because of that, in 26% there are chances of twin transfusion syndrome, TRAP, all these complications. And so they have to be monitored with Doppler every 15 days, whereas a dichorionic can be monitored every 4 weekly. So a very, very significant role of nuchal scan or first trimester scan in twin pregnancy to try and find out whether it's mono or dichorionic pregnancy. So all in summary, I would like to say that nuchal scan has important functions like accurate dating, because your entire fetal growth restriction management is based on that, and aneuploidy risk calculation, picking up structural anomaly, prediction and prevention of preeclampsia and fetal growth restriction, and a very, very crucial role in deciding chorionicity in multiple pregnancy. So Nicolaides in 2011 started, it made this attempt to invert the pyramid of antenatal care. And in 2023, we all from entire world have joined hands with Nicolaides to try and invert this pyramid, get maximum information at 3 months, and help our patient reduce complications of pregnancy. And as a chairperson for FOGSI Imaging Science Committee, it's my wish to see that every obstetrician learns and refines the skills of ultrasound, because every patient that walks in a chamber needs ultrasound. So with this, I would conclude my talk. Thank you so much for patient hearing. Thank you.
Thank you, Dr. Bela. This was super brilliant talk. And I think the teacher is one who keeps glued you to the screen, and you are just doing your duty in such a refined way. So I request Dr. Alka to conclude this session. And we would have questions in the end if you can join after the webinar. Just one question I wanted to ask. Can we take help of TVS in case patient is very obese and the position is not good?
Very much. That's what I said. That's one of the advantage of nuchal scan. Many a times we do TVS, especially for cardia. For heart, we do a transvaginal scan. We get beautiful imaging of heart and even other structures of fetus at nuchal scan, especially obese patient, previous car patient. We always try and look at the anomaly through TVS. I do see Dr. Deepika Deka here.
Yes, welcome, Deepika ma'am. It's a pleasure to have you here. Welcome. So,
I've been listening from the beginning. An excellent talk.
Thank you, ma'am. Thanks. It's my honor to have you here.
It's my pleasure.
It's an honor for all of us, ma'am, to have you here. Yes,
Thank you, Dr. Mittal. Thank you for invitation.
In early pregnancy is really something very helpful, especially for the patients who have anomalies, and they can be terminated early and without much discomfort to the patient. Although losing a baby is very traumatic for patients at times, but going in for the second trimester abortions for anomalies and doing them in first trimester is quite different. So we need to counsel the patient and really help. This is really very good. And seeing Dr. Deka here, ma'am, I like your input also, please, on this.
Yes, this is a very important step in the antenatal management of cases by obstetricians. The timely referral to the radiologist or the ultrasoundologist, that's very important. There are some anomalies which can also be detected earlier on, not just the NT scan, the first trimester, as you had shown, Dr. Bela, that, that we can see high drops sometimes and encephalitis, even in the dating scan. So it's very important. What the obstetrician, as she rightly said, should know when they read the report, and they should look at the picture, whether it has been taken in the proper plane. So that is the biggest problem which is happening. the pictures are not taken in the right plane, and we get so different, the reports. So obstetricians who are not doing ultrasound, they should know how to see which is the proper plane. They should see whether they can see the double equal sign, whether they can see the palate. Those things they must know, even if they are not doing the first trimester anti-scan. So this is important for the obstetricians to attend such lectures so that they know what to see in the report.
Thank you, ma'am. Thanks a lot. And now I invite our lovely, lively, and beautiful Secretary, Rewari Obs Gyn Society, to invite the next speaker. Over to you, Dr. Anubhuti Singla.
Thank you, ma'am. Thank you so much for a lovely introduction. And it is really an honor to introduce Dr. Seema Mittal, ma'am, who is very near to all of our hearts and has the honor of setting up the first IVF center in whole of the Haryana. Ma'am has been the past president of Rewari Obs Gyn Society and secretary of Doctors for Society. She has been awarded by President for Sukhad Matritva book, which was written by her, and local champion award by Government of Haryana. So ma'am is always there to guide and help us. Thank you, ma'am, for being always there. And I welcome you, ma'am, to guide us as to when to refer a patient for IVF.
Thank you, Anubhuti. Thank you for the kind introduction. And being into IVF and infertility for almost 3 decades now, I feel now every third patient coming is demanding IVF, as infertility has become a problem worldwide. So it becomes our responsibility to see whether we should refer every patient who is coming to us for IVF, should be taken for IVF, or there should be a guideline. Of course, there are guidelines, but before guidelines, we have to know what is infertility exactly and how, as a primary and secondary caretaker, we can do for the patient. Infertility is a serious health issue worldwide. So now almost 8 to 10% couples worldwide are affected by infertility, and out of all 60 million, I think 15 to 20 million are in India alone. So we have the bulk. So techniques that involve manipulation of oocyte outside the body are termed assisted reproductive technology. The term in vitro means living outside a living organism, as oocyte matures in vivo in the ovary and embryo develops into pregnancy in the uterus. But the oocytes are fertilized in the petri dish, so the name is test tube baby, which is more common with our patients. So 10 to 15% of the couples will have difficulty getting pregnant, and now we define infertility as no conception after 12 months of unprotected intercourse in women less than 35 or 6 months in women over 35 years. Females can have a whole lot of problems like oligomenorrhea, endometriosis, tubal disease, and the workup for couple experiencing infertility includes assessment of all these factors like ovulatory function, tubal patency, uterine cavity, and the semen analysis. If there is evidence of endometriosis, tubal occlusion, or adnexal adhesion, then most of the patients go for IVF. But what we suggest that a diagnostic laparoscopy must be done for all the patients having these problems. And there are fair chances in our practice, what we see that almost 40% of these patients do get pregnant on their own, those who had come for IVF alone. So initially developed as a way to bypass irreparable tubal damage, IVF is now widely applied for treatment of infertility due to a variety of causes, which include endometriosis, male factor. Male factor is becoming more common nowadays, and unexplained infertility, which is explained, once you take up the patient for IVF and you realize that there is nothing unexplained in an infertile patient. So women who cannot use their own oocyte, definitely it's a blessing for them. They can go for a donor oocyte IVF. So although ART was developed for patients with tubal infertility only, but currently it's used for almost all kinds of infertility problems because success rates are expected to be higher than those of the conventional treatments. But as a clinician, we have to know that it has got certain disadvantages, and it involves greater expenses, potentially serious complications like OHSS and multiple pregnancies. And there are fears, although we don't have very long duration of exposure, almost 40 years IVF now, but there are fears that drugs that induce ovulation may increase the chances of ovarian cancer. So It is very important to refer proper patient at proper time for ART, and it's for the ART specialist also to segregate and analyze and only take, once the parameters are excluded, then only take a patient for IVF. Various categories of infertile couples that we come across in our clinical practice are those with single defect in one of the partners, that's very easy to treat. Those with multiple defects in one or both the partners, and there is no apparent defect in either partner. As I said, unexplained is explained once you take up your patient for IVF. So what are the conditions for which patient should be referred for ART? So let's go to female factors first. So tubal disease still remains the mainstay for IVF, where microsurgical techniques, now we have such wonderful microsurgical techniques, surgeons and everything available that unless the microsurgical techniques for tubal and peritoneal disease have failed or unlikely to benefit the patient, we don't take up the patient for IVF. Presence of dense peritubal adhesions, condition of the tubal wall, condition of the ciliary epithelium, that's why tubal function test is very important, and degree of embryal damage are all what gives us a clue to go for IVF. And most important, which we find in our patient when we are doing diagnostic histolapro, that tubes are patent, but there is total loss of tubo-ovarian relationship and patient does not conceive in spite of repeated cycles of treatment. So approximately 25 to 35% of infertile women are found to have tuboperitoneal disease. So commonest cause of infertility also, and commonest reason for taking patient for IVF. Pelvic inflammatory disease is the most common cause of tubal damage, and it's usually the result of chlamydia infection. And they can result in tubal occlusion or peritubular adhesion that render in vivo fertilization unlikely. IVF bypass is the tumoral damage by transferring embryo directly into the uterus. Tuberculosis is most rampant, especially in our Haryana and our area. It is so common. At least one patient out of 20 does have evidence of tuberculosis. And now when we are doing diagnostic lapro, we see fluid in POD, we send it for cytology, and the pathologist tells us then the picture is exactly like what happens in tubercular ascites. So it is much more common than what it is visible on investigation. So bilateral hydroswalpings, or patient who has undergone tuboplasty already, or recurrent ectopic pregnancies make an indication for IVF. Uterine factors like Mullerian agenesis or adhesions or hysterectomized patients with ovaries intact can go for a surrogate mother. Ovarian factors are also very important. Nowadays, we are overdoing with the ovarian factors like hypogonadotropic anovulation or luteal phase deficiencies are very common in infertile patient. But what we know from experience that if the patient has any of the ovulation defects, laparoscopy and the drilling does wonder. And most of the patients you will find a mild degree of endometriosis, and treating that part takes care of everything if it is done in time. So women who are unable to produce their own oocytes due to insufficiency or diminished reserve are able to become pregnant with donor oocyte. That's the blessing of this world. IVF cannot overcome the impact of age on oocyte function. So our donor should always be less than 30 years of age. That is what we take in IVF. IVF is also utilized in women who desire to preserve their fertility. Now the trends are changing: late marriage, career consciousness, corporate culture, and the diseases. So women with cancer or other illness may undergo gonadotoxic treatment. They would like to freeze their eggs, which can be used later on, or in women who want to delay childbearing for certain reasons, the ambitions or the job preferences. So we all know that after fourth decade, dramatically the fertility is going to decline. So this drop in fecundability is a result of decrease in oocyte quality and quantity. So patients who are not interested in pregnancy in near future can cryopreserve their eggs. Cervical factors also, if we have made recurrent attempts at IUI and they fail, doesn't make an indication as such for IVF. Endometriosis, yes, in today's world, it is decreasing incidence of endometriosis is alarming. And women with moderate to severe endometriosis, yes, they do need IVF at times. So medical or surgical therapy, see, dictum about endometriosis is you either treat endometriosis or you treat infertility. You can't treat both. So once we decide to take a patient for infertility treatment, we do a proper baseline hormonal assessment, a laparoscopic assessment, and if we find that tubes are irreversibly damaged or there are adhesions, we take a patient for straight away for IVF without wasting time. And as soon as you finish your surgical treatment, patient should be taken for treatment of infertility as soon as possible, because endometriosis is always progressive disease. There is nothing permanent cure like in endometriosis. So it's a chronic inflammatory disease which is defined by presence of endometrial tissue outside the cavity, more prevalent in female with infertility, and mechanism of endometriosis in causing infertility is still not understood in spite of detailed researches. And patient has pelvic adhesions, there is chronic intraperitoneal inflammation, disturbed folliculogenesis. Eggs are usually less in number, poor in quality that we see in IVF, that there are poor embryos, and decreased embryo implantation as well, because it affects the endometrial receptivity also. So laparoscopic surgery has been found to increase this is a debatable topic again, but I am just talking of what we see in our practice, that laparoscopic surgery has been found to increase the rate of pregnancy. And literature also says that from 4.7 to 30.7%, indicating the importance of restoring normal pelvic anatomy for spontaneous pregnancy. Unfortunately, women with endometriosis have significantly lower success rate with IVF compared to other causes of infertility. So use of donor oocyte and donor embryo, we all know in patients who have undergone menopause prematurely or at timely menopause, but there are certain genetic disorders, radiation therapy, or ovaries which are not accessible by ultrasound due to severe adhesions. Male factors, yes, now with increased use of hookah bars, alcohol, male factors are overnumbering the female factors, and poor semen quality is the sole cause of infertility in 20% of couples and contributes to fertility issues in another 20%. So decreased sperm count, motility, they all can be treated partly medically, and I don't think surgery helps much in such cases. And intrauterine insemination does increase pregnancy rate in couples, but not to much extent. And if such treatment fail, then we take a patient for IVF with or without FOGSI. Sperm extracted from testicular epididymis, FOGSI has to be done because the sperms have not undergone the final in vivo maturation process, allowing it to fertilize an oocyte. So semen abnormality can be low concentration, low motility, or abnormal morphology. Unexplained infertility, as I say, there is nothing unexplained, but yet you have tried everything possible, nothing looks abnormal, and patient is not conceiving. But retrospectively, when you've taken up your patient for IVF, you realize that it could be because of many factors, such as subtle ovulation defects, defects in gamete transport, tubal environment, sperm abnormality, and there can be oocyte abnormality also. At times, we have taken up patient for IVF, but there is no fertilization, and we realize that egg shell is very thick, and we have to do FOGSI, and next time patient conceives. So nothing is unexplained. It is just maybe the compatibility is the issue, or the quality of egg. Multiple eggs are seen on ultrasound every time. It ruptures in time, but when we do the pickup, it's only the empty follicle. So unexplained becomes explained once you proceed further. And patients where you've tried, you can take them IVF. IUI, we are not talking much about IUI. There is from husband or from donor, and if it's hostile uterine cervix, oligospermia, unexplained infertility, but we try IUI and if it fails, we have to take up patient for IVF. So indications for IVF ET will be when there is irreversible tubal pathology or surgical damage, subnormal male factor, idiopathic infertility, endometriosis, or infertility of immunological origin. FOGSI is done when there is severe male factor infertility and fertilization failure, as I said, after standard IVF treatment, and number of spermatozoa in the ejaculate is too low for IVF. Or other procedures that we do are MISA, PISA, TISA, everything when there is anejaculation or there is retrograde ejaculation or non-obstructive azoospermia, FOGSI does wonder. Oocyte donation is done when there is gonadal degenesis, ovarian failure, iatrogenic failure, poor responders to ovulation induction. Embryo donation is another boon of IVF when there is primary germ cell failure or there are inheritable genetic disorders. Pre-implantation genetic diagnosis is another area where IVF cycles are very, very important. For patients at risk for genetic disorders, autosomal dominant like Huntington's chorea or other autosomal recessive disorders, or X-linked disorders or chromosomal disorders, IVF is recommended, where we do pre-genetic diagnostic technique and find out, and that pregnancy can be terminated or continued. Unsuccessful IVF cycles again call for, if their cycles are unsuccessful, then we have to do genetic testing to know any chromosomal abnormality. So few things we have to remember before referring the patient for ART. Our patient selection for referral and ART should be based on the finding of basic investigations on the cause of infertility. So nowadays we find patients where all the basic investigations have been denied, just 10 years infertility, and directly go to IVF center. It's a wrong practice. And IVF center also, without even looking at the uterus or the uterine cavity, IVF is done 1 cycle, 2 cycles, 3 cycles, and patient comes to us. We simply put in a laparoscope, do a diagnostic, and she conceives. So patient selection should be based on finding basic investigations. And there are nice guidelines that if the woman reaches the age of at least 2 years of trial should be done if everything is normal in less than 40, though we don't do it in practice. And if woman reaches the age of 40 during treatment, complete the current full cycle, but do not offer further cycles, but you go for IVF. So according to guidelines, so what we follow is where investigations show that there is no chance of pregnancy with expectant management, and where IVF is the only treatment, refer the patient directly to a specialist team for IVF treatment. Otherwise, do the basic test, basic treatment, and if that fails, only then you take up the patient. So we have to know that explosion of knowledge about human reproduction and a greater understanding has increased our scope of applying ART, but it should not be abused or embarked upon too early. IVF is a test of fertilization. It gives hope to women with ovulatory dysfunction, tubal disease, and a host of gynecological conditions. Micromanipulation techniques have revolutionized the treatment of male factor and couples with a history of poor fertilization. Surely with time, more and more awareness, we would cover yet another indications for this. But the most important part, which I feel that we should keep in mind, is the stress and ART. When couples have fertility problem, the stress in the male or female can affect their relationship. It does affect the relationship, and it has all its repercussions on libido, hormonal effect, and it has been reported as the most stressful of all infertility treatments. So ART should not be done. It should not be taken very lightly, and women have more anxiety. You see in your OPD every day lots of females crying, and then you have to really sit and meditate to get over that, all that negativity or the anxiety that they pour onto you. And unsuccessful treatment raises women's level of negative emotion. And so net result is again consecutive unsuccessful cycle. So we have to counsel, sit, talk, and we should have empathy. That's my principle, that you have to put yourself into their shoes, and you should have sympathy, understand from your own perspective whether I'm doing the right thing, am I able to diagnose, I'm able to treat and refer the patient in time. Financial aspect has to be taken into consideration. Our patient, we are from a small town, our patients are very poor. Most of the time, somebody is selling the buffalo, somebody is selling the house, and they're coming for IVF. So post and treatment and alternative option should always be offered to the patient. And Ashok sir has come, so I will be skipping slides, but we have to know the side effects of the treatment, because despite the fact that treatment has been established for last 40 years, almost 4 decades, but the studies on the side effects are barely 20 years ago. And wherever we have the more number of cases, the study period is short. So we have to know that anything we are putting into our patient, if it has effects, it will surely have side effects. In our practice of almost 30 years, I have seen at least 2 patients of malignancy, and directly, indirectly, somewhere I feel responsible, because the patient had undergone multiple cycles. She did conceive, but ultimately ended up with a tragedy. So there are few contraindications also, as we know. Any heart problem, major physical or medical disorder, we do not take patient for IVF, and this patient has to be advised for surrogate. So we still hope, and something against all odds, against all logic, we still hope, and we really pray to God that every mother on this earth is blessed with a beautiful motherhood. Thank you for your patience and your time. Thank you. Over to Anubhuti.
Thank you, ma'am. Thank you so much for enlightening us and making us more wise in making a decision in patient's favor always and always. And after proper investigation, and definitely our decision for referring the patient for IVF should not only be based on how much married life she has been there, or what is her age. We should properly investigate her and the husband also, and then we should decide in their favor. Thank you, ma'am. Thank you so much for the talk.
Thank you, Anubhuti. And now we have two doyens from gynae and obstetrics. So we have Dr. Ashok Kumar sir, who needs no introduction actually, but I will request Brigadier Dr. Sunil Takyar to introduce our teacher of teachers, Dr. Ashok Kumar, who would be talking on the topic which was so much in demand, that cholestasis and pregnancy. Over to you, Sunil sir.
Thank you so much for displaying my image and this small whatever I have to offer about myself. And I heartily welcome Dr. Ashok Kumar, who is the professor and HOD of Obs and Gynae, MD and PhD by himself. He is at Dr. Ram Manohar Lohia Hospital with that Atal Bihari Vajpayee Institute of Medical Sciences. He is presently the secretary of ICOG for the 2021-23 term. Eminent educationist, a prolific writer. He is on the editorial board in medical disorders and high-risk pregnancy. And he has basically numerous research papers. He has edited chapters and books. He has conducted research workshops for ICMR and UGC. I think rather than my delving into the topic of hepatobiliary disorders in pregnancy, because as we all know, it is not only the liver, it's the gallbladder, the pancreas, and basically whatever we divide the liver disorders in pregnancy, whether it is a pre-existing anomaly, whether it is something which has been aggravated by pregnancy and passes off on its own, or these are the disorders which are just coincidental to pregnancy. So now I welcome Dr. Ashok Kumar to deliberate on the topic of IHCP, as we fondly call it. Over to you.
Good evening. Thank you very much. First of all, at the outset, I would like to express my sincere thanks and gratitude to Lalita Memorial Hospital, Rewari, and Dr. Seema Mittal. Thanks to Dr. of Rewari Obs Gyn Society, all members of the society, for giving me this opportunity to interact with you. Thank you, Brigadier Takyar Saab, for your nice introduction. And I thanks all seniors and eminent personalities of obstetrics and gynecology, Dr. Deepika Deka, Dr. Amita Yadav, and obviously Dr. of Rewari Obs Gyn Society. So today I bring greetings from Atal Bihari Vajpayee Institute of Medical Sciences and Dr. Ram Manohar Lohia Hospital, New Delhi. And I will be talking on obstetric cholestasis. Or, as you know, this is the cholestasis of pregnancy, and different names have been given to this entity: intrahepatic cholestasis of pregnancy, or pure obstetric cholestasis, or cholestasis of pregnancy. Basically, it refers to a condition which means it impairs the flow of bile from the liver. And you must be all aware that bile is very important for us. It is a digestive fluid produced in the liver, and it helps in breaking down the fat. From the undergraduate days, we have learned liver diseases unique to pregnancy, and intrahepatic cholestasis of pregnancy is a liver disease unique to pregnancy. And we have also learned that from the second trimester or third trimester, we can have this problem. The other differential of this problem might be preeclampsia, eclampsia, HELP syndrome. And in on the third trimester, it might be acute fatty liver of the pregnancy. Then we can have pre-existing or coincidental liver disease also, which may be there before the pregnancy, which may be continuing during pregnancy also. So what is this obstetric cholestasis? It is not a problem. It is more than a problem. It is more than just an itch. Itching is the main problem in this. But we are not limited to itching. It has so many other associations and other associated issues. So it is basically defined as condition of pregnancy by pruritus, and biochemically there are elevated serum bile acids in association with other signs of liver dysfunction. Basically, what we have to keep in mind is that ICP is a diagnosis of exclusion. We have to exclude other causes of cholestasis. The incidence varies on the geographical location, but it is around 0.5 to 4%. And recurrence rate is very high. It is 45% to 70%, and in some literature it is reported as high as 90% also. It is a familial disease also. So the risk factors includes multiple pregnancy, the women who have undergone IVF treatment, if there is a history of liver damage, patient of chronic hepatitis C, advanced maternal age, and past stage. I told you recurrence is very common. Clinical feature starts from the skin changes. You see there scratch marks, and it may be excoriations also. But the main hallmark is the itching all over the body in the absence of eruption. That is very important to understand, that there are no rashes. But because of the scratching, because of the itching, there might be secondary skin changes, as I've shown you in the earlier picture. Pruritus is very common on the palms and soles, but can be anywhere. It is worse at night, and sometimes it is so severe that it affects the lifestyle of the patient. It is usually precede biochemical derangement. And you know why it is occurring? Because of the elevated bile salts. They activate receptor on the cutaneous afferent neurons, thereby elicits a scratch response. So it is very disturbing to the patient. Anywhere, typical pictures of itching. Then there might be other associated symptoms because of the liver impairment and fat malabsorption, because this enzyme is digestive juice is lacking. So jaundice due to elevated bilirubin, malabsorption of fat. So patient will have pale cluster stool, impaired coagulation secondary to reduced vitamin K absorption. There is reduced enterohepatic recirculation of bile acids, which results in malabsorption of fat and fat-soluble vitamin. So vitamin K problem is there. So how to make a diagnosis? Diagnosis we usually make on the clinical feature and the lab features both. Clinical feature, I told you, pruritus, mainly over the palms and soles, but anywhere in the body in the third trimester, or maybe in the late second trimester. And important component of diagnosis is that spontaneous relief of sign and symptom within 4 to 6 weeks postpartum. So this problem resolve in the postpartum period spontaneously. In the laboratory finding, transaminases are normal or slightly elevated. Usually they are not more than 3-fold rise. But this is a very common finding in 60% of the patient. Serum alkaline phosphatase is very high, 5 to 10-fold. Bile acids is also a main important component of diagnosis. Usually 10 is the normal, 10 micromole per liter is the normal value. So more than 10 is, and we can classify according to the levels. more than 10 is mild, more than 40 is severe. Then elevated serum bilirubin, but bilirubin is not more than 5. Sorry. And this patient may have mild jaundice. Jaundice may be seen in 20% of the cases. Then other two important components which are there is the negative viral markers. Marker of hepatitis A, B, C, and E, they are negative. And patient have normal ultrasound of the liver. So when these components are there, then we make a diagnosis of cholestasis of pregnancy. So this is very important that we have symptom of pruritus, we have alkaline phosphatase which are high, transaminases are not very high, they are moderately high, bile acids are very high, and in the setting of negative viral markers and normal ultrasound liver, and simultaneously we have to rule out any other dermatological condition. Commonly, we have to rule out the patient is not suffering from scabies. So these things we have to take into consideration before we label the patient of pruritus with cholestasis of pregnancy. There are different etiological factors. It is a disease of multifactorial etiology, environmental, genetic, endocrine. So just briefly, genetic factor is very important to consider. It is a multi-drug resistant protein 3. So there is a mutation of this MDR3. And this protein is involved in the biliary secretion of phospholipids. So when there is a mutation, this impairs the transportation for phospholipid across the clinical membrane of the hepatocytes. Therefore, there is a rise in the bile acid. So this mutation, along with mutation in BSEP gene, BSEP is bile salt export pump. So this defect in there are 6 biliary transporters. These are biliary transporters. So the mutation in these transporters in liver known to be associated with ICP. So these two things are very important at the genetic level, and therefore there's an increased risk in the first degree relative, which is observed in this condition. In endocrine factors, the main issue is of the estrogen and progesterone. There are high levels of estrogen and progesterone in the third trimester. And what happens that sulfated progesterone metabolites, they are known to reduce hepatobiliary bile acid efflux. That is why there is a increased intensity of cholestasis. And this can be triggered in women who were already on high dose of OCP before pregnancy. Similarly, estrogen also play a role in multiple gestation. If you see the incidence of this problem is 14% in twins, 43% in triplets. So multifold rise as the number of fetuses increases. And because of the changes induced by the genetic mutation, which leads to the increased sensitivity to estrogen. And these sex hormone, they again exert cholestatic effect via inhibition of hepatocellular bile salt export pump. And this impaired sulfation because of the estrogen and progesterone, hepatic transport mechanism for biliary excretion can be saturated by these sulfated progesterone metabolites. So eventually, the buildup of bile in the liver allows bile acids to enter the bloodstream. And these bile acids deposited in the mother tissue, and that can lead to the itching. This involves the placenta also and the fetus also. In the placenta, they have different genes, they differentially express. And the direct effect of bile salts on placental vasculature has been postulated, leading to placental dysfunction. And bile salts also known to cross the placenta. So fetal effect occur due to placental dysfunction and high level of bile acids. So placenta and fetus both are involved. If you see here, total serum bile acid concentration, bile acid hydrophobicity index, and peak maternal total serum bile acid and enzyme concentration. They affect the NT-proBNP and affect the fetal heart. Maternal total serum bile acid concentration increases the PR interval length and increases the heart rate variability. This is of the fetus. So possibility of sudden death, fetal death, sometime within hours of normal fetal heart racing can occur. Why? Because of the bile salts, these taurocholates, these are the metabolites, they crosses into the fetal compartments and affect the cardiomyocytes and cause fetal arrhythmias and decrease contractility of the cardiac musculature. It increases PR interval and placental chorionic vein congestion when exposed to bile acid folate as a possible cause of acute fetal distress, fetal asphyxia, and death. So these bile acid is harmful to the placental vasculature also and to the cardiomyocytes of the fetus. Then adverse outcome which has been observed in the fetus during pregnancy are meconium staining of the amniotic fluid. Bile acid stimulates fetal gut motility, odd ratio of 2.6. Spontaneous preterm labor can occur. Bile acid increases aspiration and sensitivity of the oxytocin receptor on the myometrium. Fetal arrhythmia, because bile acids impair fetal cardiomyocyte function and may lead to sudden IUD. Fetal asphyxia, stillbirth due to bile acid-induced placental dysfunction. The important thing which we have to remember is that stillbirths are unpredictable. It can occur suddenly, and it can occur in a normal grown fetus without any evidence of chronic placental insufficiency. So you have to be very careful with these pregnancies. And in the neonatal period, there might be neonatal respiratory distress because bile acid reduces lung surface rate. So different parts of the complication: fetal growth restriction, premature birth, meconium stain amniotic fluid, neonatal respiratory distress syndrome, heart arrhythmias, fetal distress, and stillbirth. Now, something more about the intrauterine fetal demise. It rarely occurs before 36 weeks. This fetal complication, which includes preterm delivery, meconium staining of amniotic fluid and placenta, and fetal asphyxia, were related to bile acid concentration within the critical limit of 40 micromole per liter or greater. So, lot of complication occur when the bile levels are more than 40. When bile acid levels are more than 100, it is associated with increased risk of stillbirth. So adverse effect and stillbirth, this we have to remember. And the critical level is 40 and then 100 is for stillbirth. This is the data which has shown that if bile acid levels are less than 40, the stillbirth rate is less than 1. But when the bile acid levels are between 40 to 100, still the stillbirth rates are not very high, they are less than 1. But as the bile acid levels are above 100, stillbirth rate is more than 3.4%. So fourfold or something, that 3 to 4 times rise in the rate of stillbirth as bile acid crosses 100. So this is very important to remember. Now the issue is how to monitor these patients. Now, there are different guidelines, different recommendations, but important thing is we have to monitor weekly liver function test for the progression of the disease, and we have to monitor bile acids throughout the pregnancy when we have this condition. So, monitoring of bile acid weekly, because level can change rapidly with advancing gestational age. Simultaneously, you have to monitor, you have to find out, and you have to evaluate for the other causes of liver dysfunction. Like I told you, viral disease or autoimmune disease or some obstetric etiology. So you by seeing the profile of the liver function test, you can differentiate whether it is of cholestasis, or it is because of preeclampsia, or because of HELLP syndrome, or it is because of viral hepatitis. So these are differential, or it might be because of chronic liver disease. So how to monitor and when to deliver? See, when we know there are very high chances of stillbirth, there are variations in the bile acid levels. They are increasing. You cannot predict the fetal death. Suddenly it can occur. So what to do? Still, recommendation is that you should do twice weekly non-stress test. Even some evidence suggests that umbilical artery Doppler should be done because it can become abnormal in obstetric cholestasis prior to abnormal NST. So one can consider using Doppler also as a monitoring tool. Fetal heart tracing on NST, you can note down in the form of decreased variability. There might be tachycardia or bradycardia. But one has to remember that these abnormalities in the fetal heart rate tracing, they are not related to fetal demise. It is not clear up till now whether antenatal testing of fetal heart or by any other means can identify fetus as risk of demise. But still, the consensus is that it should be used. We are still using it, although it doesn't help in prevention of fetal demise. But we have no other option. We have only NST, biophysical profile, or Doppler studies, which we can do to find out any abnormality. If it is well, we can pick up the abnormality and we can act upon. Now, this is the latest which has come in the literature, is that they have correlated the timing of delivery as per the bile acid level. This is only by the Society of Maternal Fetal Medicine, RCOG, ACOG. Nobody has given these type of differentiation. So let's see what they have given. They have given that bile acid above 100 if it is there, it is a high risk group. So you deliver at 37 weeks, 36 weeks also. Bile acid between 40 to 100, delivery between window of 37 to 40, right? But they say you deliver earlier in this window period. So don't go beyond in the late, like 38, 39. So again, emphasizing, although they have given a window of wide period of 4 weeks, but they still emphasize that deliver as early as possible in this window. The last is the lower risk group. That means bile acid below 40. In that also, they say you deliver in this window and you can take your time and when you want to deliver. So this is the only difference. Only thing is that they have highlighting that although window period is wide, but deliver early. So that is the message from there. But you can deliver before 36 also if bile acid levels are more than 100 micromole per liter and patient have very severe non-responding pruritus. Patient have history of previous stillbirth, or patient have acute or pre-existing hepatic disease with clinical or laboratory evidence of worsening of hepatic function. If your LFT is deteriorating, still you should consider termination of pregnancy. So these are the specific red flags which you have to keep in mind when you are managing these patients, and you should not hesitate to deliver as soon as they reaches 37 weeks or 1 or 2 weeks earlier also in these situations. ACOG recommends that you deliver by 37 weeks. They also state that delivery before 36 may be indicated depending on laboratory and clinical circumstances. RCOG also says you deliver by 37 weeks. Now, if you have not reached 37 weeks, patient has problem. The main problem is of pruritus. So how to manage these? we have very good drug now, ursodeoxycholic acid, UDCA, or commonly we say UDLIV, or different names. So it is the most commonly used drug. It stimulates hepatobiliary secretion. It protects hepatocytes against bile acid-induced apoptosis, and it inserts a key translocator or transporter protein, which improves bile salt export from the liver and therefore reduces the risk of any adverse effect to the fetus. So this is all theory, but these are the mechanism of action of this drug. Now there are different studies which have found out that this drug decreases the pruritus score. It improves the bile acid level, improves the enzymes, and it reduces rate of preterm delivery. These are few important studies which I want to highlight. This is the PRISMA compliant study of 12 RCT. It all highlighted that UDCA is effective and safe to improve pruritus and liver function. It reduces adverse maternal fetal outcome. Then this is the PITCH trial, pregnancy intervention trial in cholestasis. It also confirms that UDLIV reduces pruritus significantly. But now we have to understand the size of benefit may be too small. It also highlighted the maternal fetal outcome, including cesarean section rate, did not differ significantly between women randomized to early term delivery and those who had a expectant management. So timing of delivery, we are not sure how much it is benefiting the patient. Then this is the Cochrane review of 26 trial. They say UDLIV administered to women with ICP probably shows a reduction in pruritus. However, the size of it is small, and for most pregnant women, the reduction may be fall below the minimum clinically worthwhile effect, and evidence unclear for other adverse fetal outcome. So UDLIV is good to improve the symptoms, but we are not sure how much improvement and how much it is going to improve the outcome. This is very important study, very prominent study of published in Lancet, double-blind, multi-center randomized trial of 33 maternity hospital. It says that UDLIV does not reduce adverse perinatal outcome. So routine use for this condition should be reconsidered. But however, because of the symptoms we are using it, it improves our liver function parameters. But how much it is translating into the maternal and fetal outcome, people are putting a question mark on that. Then another drug is cholestyramine. This is a strong iron exchange resin which binds to bile acid in the intestine. Then the problem with this is it is not considered first-line drug because there is this concern surrounding the associated decrease in vitamin K levels. And it has a lot of severe GI side effects in terms of diarrhea, nausea, vomiting, and pain in the lower abdomen. So one has to be careful. It is not very commonly used, but yes, wherever you feel UDLIV is not working, then one can think of these drugs. Other is rifampicin, which has also been tried, and it has been found that it is useful in women with, you have to understand it, for severe and resistant disease to monotherapy with UDCA alone. So severe condition and resistant to UDLIV. So there, in those situations, it is useful in reducing the bile acids and pruritus in 50% of the women. It is used in combination with, obviously, with UDCA. Then we have other drugs. We can use dexamethasone, steroid, and we have S-adenosylmethionine, SAM. However, still controversy is there whether we should use this or not. Then we have to manage vitamin K deficiency. And if it is there, it is associated with fetal intracranial hemorrhage. So we have to see that we give vitamin K only if we find PT is prolonged. So when these patients of cholestasis of pregnancy, we are planning for induction of labor, or when they go in labor, we have to have prothrombin time with us to see whether it is abnormal or not. If it is abnormal, please give vitamin K injection. Then planned delivery. See, we have to consider from the maternal point of view, main problem is of intense pruritus. And as pregnancy increases, it will become intolerable. So we have to consider delivery as near to as possible to 37 weeks. From the fetal point of view, we know the risk of fetal demise is there even with our treatment, because they may or may not be affecting the fetal outcome. So from their point of view also, we have to think and advocate termination of pregnancy around 37, because that is the term labor. Then we have to think otherwise also, that if there is significant rise in bile acid, or there is a persistent increase in transaminases or LFTs abnormality, which persist, doesn't improve with UDLIV, you have to consider termination. What about follow-up? We have delivered the baby. Follow-up is very important, because follow-up postpartum monitoring of bile acids and LFT should be done 4 to 6 weeks to ensure resolution. Because if there is no resolution, that means further evaluation is indicated to rule out an underlying genetic disorder or chronic liver disease. And this is the best time to evaluate the patient again, because, you know, patient has very high chances of recurrence. So try to find out whether patient has any known etiology for this condition or any other problem of chronic liver disease. Long-term complications are very important to understand. Now, this is the main focus. Like we are talking of long-term complication of diabetes, we are talking of non-communicable diseases after pregnancy. So there are so many things we have to have focus. So for this condition also, women with ICP have slightly higher long-term risk of cancer of liver and biliary tree, as well as higher rates of other hepatobiliary diseases. And most commonly, we have to understand that gallbladder stones, cholelithiasis, is also associated with this condition. So it is better to have ultrasound of liver when we are talking to rule out the condition of liver. Look at the gallbladder also for cholelithiasis. This is the landmark study from Sweden. If you see, more than 11,000 women with ICP have been evaluated, and they found, and the period you see from 73 to 2009, they found that increased risk of variety of immune mediated disease such as thyroid disease, diabetes, psoriasis, and Crohn's disease. Then there's an increased risk of future cardiovascular disease, but only in women with ICP and preeclampsia during pregnancy. So another condition is liver and biliary tree cancer, which I have told you earlier also. So many long-term complications which we have to understand this disease can have. So it is better to keep a watch on the patient. So just to now summarize and try to highlight the messages, UDLIV improve pruritus and bile acid level and liver function test also. But we are not sure whether it will improve fetal outcome or not. Antenatal testing is recommended, but proven benefit has not yet been shown. But still, we do some literature support practice of elective early delivery. But time, still we don't know. Most of the guideline now recommends that we should deliver by 37 weeks, 38 weeks. Usually in my practice, I never go beyond, as soon as patient completes 37 weeks. That means we just remove the label of preterm delivery. We try to induce the patient and deliver them. ICP remains a common, dangerous, and poorly understood complication of pregnancy, for which continued investigation and observation is warranted. So maternal outcome for patient diagnosed with cholestasis is good, but we have to understand that it has long-term sequelae also. And we have to also keep in mind the fetal outcome, which can be very severely bad. We can have other problems as well as stillbirth. So early recognition, treatment and timely delivery is very important. In the management, we have to just keep focus on the LFT and serum bile acids. We should not monitor these patients without bile acid. It should be done. We should do strict fetal surveillance as we do for high-risk pregnancy. We have UDCA in our armamentarium for managing these patients, and we have to plan delivery at around 37 weeks. So don't ignore this itch. This is very important. It could be ICP and the baby life is at risk. So one has to keep in mind this. Thank you very much. I thank Dr. Seema Mittal for giving me this opportunity. Thank you very much.
Thank you,
Thank
Dr.
you
Ashok
so-
Kumar. It's really nice that you have talked about the other itch. So I hope this goes a long way in improving our understanding of the situation. And of course, things like timely UDCA intervention and a periodic monitoring and the bile acid levels will definitely help the patient. Thank you so much.
Thank you, Ashok sir. Sir, it was indeed evidence, experience-based, enlightening talk, and this was much awaited talk by all our audience. And I'm sure all the queries, all the questions are answered. So just one question: that when you are putting the patient for induction, do you give them steroids before induction, or just 37 is enough? Like,
No, at 37, we are not giving any steroid.
and they deliver normally, because literature says that cesarean is not recommended, but most of our patients have a meconium sort of thing when we are inducing and just doing ARM, and even I
No,
had
they
my
are at-
cesarean because of this.
Yeah. You know, they are at high risk of meconium. As I told you, it is a very known complication, non-finding in labor, amniotic fluid meconium. But we induce them at 37 weeks and we see how they progress. Let's see. But yes, there are high chances of meconium. And if meconium appears in early labor, we obviously have to go for cesarean.
And very important point which you told us, sir, was that there may not be any chances of placental insufficiency. At least one baby we lost because the color Doppler parameter, everything was perfect, and
Yes.
still the baby was lost. So this is a very important take-home message for all of us, that clinical assessment should supersede all the investigation parameters.
I also cannot forget the one patient in my early career, like about so many years back. From there onwards, I am very careful for these patients, even if they have bile acids of 10 or 20 or 25, because this was a twin pregnancy and we were just normally, she came into spontaneous labor at 37 weeks, and in labor only, she lost both of her baby. Because of meconium and all these complications. This was a patient of ISCP. So I cannot forget that patient up till now. And that have decreased my threshold level for these patients. Because when a stillbirth occur for or IUD occur for a pregnant lady at near term, you can imagine the trauma. So by waiting 1 or 2 days, you are not gaining anything.
Right.
At 37 weeks or even at 36, 4 days or 36, 5 days, doesn't matter if bile acids or patient is suffering from ISCP. And important is to remember her past obstetric history also. That is very, very important. And take decision accordingly.
Thank you, sir. And we have now Dr. Deepika Deka also. So can we have the questions, because ma'am will enlighten us on so many topics which we have not discussed in our talks so far. So Deepika ji, can we have the questions? So before that, we have Dr. Deepika Deka, who is a gold medalist, and she, I mean, it's a very small.
There is a question in the chat box. Can I answer that?
Yes, sir, definitely. So please,
Yeah,
our pleasure.
This
Yes,
is
sir.
they are asking about fasting or post meal. Actually, this is a dilemma up till now. But
Yes, sir.
what I have read, I have also searched specifically that what should be done. But usually now they are saying that fasting is still to be done for fasting bile acid.
Okay, so it is fasting only, sir?
Fasting. This is what there might be some difference of opinion because in some of the places postprandial also written, but when I have searched many places and I found that fasting is good enough to provide all the information.
Sir, how effective are SGOT, SGPT? Like we were going for SGOT-PT till we read about your lecture.
No, SGOT-PT is not bile and alkaline phosphatase. We have to see bile, then alkaline phosphatase. Then you go to SGOT-PT and then you go to bilirubin.
Right, sir. Right, sir. Thank you, sir.
Yes, actually, bile acids are the hallmark now. Earlier, we
Yes.
did not have. I remember when I was even faculty at AIMS, we didn't have. It's just started about 10, 15 years back. We have the easy accessibility. So bile acids are better than SGOT-PT.
So, ma'am,
See, I can also tell you the growth, how it grows. When I was resident, you don't have from the hospital lab, bile acids were not estimated. Dr. Deka is telling right. So we
Right.
used to manage by the LFT and SGOT-PT only. When I moved to MAMC, there also you don't have the bile acid. So we used to manage only with SGOT-PT. But slowly we learned that bile acid is important. So we used to get it done from outside because without bile acid, we cannot manage. Now in RML hospital, bile acid is done in-house. So we have no problem in having the bile acid. So slowly the period and time is changing. So we are getting more and more aware and we are making these facilities available.
Thank you, sir. Thank you so much. Thank you, Deepika ma'am. So we have actually, Deepika ma'am, if you want to add anything which have been missed in our lecture, you can add or we proceed to questions that we have to ask you certain questions.
No, he has given a most elaborate lecture. I'm proud of you, Dr. Ashok. He is our
Thank you.
student. And I think it's very clear now for everybody how to manage cases of intrahepatic cholestasis.
Thank you, ma'am. I mean, it's a real pleasure to have you, Ashok sir, Sunil sir, everybody on this platform. So, Deepika ji, can we have the questions for ma'am? Always pleasure connecting to them. So, ma'am, Dr. Bela has already discussed actually best time for nuchal scan. So, we can just ask you the questions like, what will you advise all the obstetrician? How many scans should be done for a patient? And what is the best time to know all the anomalies?
You're asking me?
Yes, Deepika ma'am. Yes, ma'am.
Okay. Right. So the best time, I have to speak offhand because I didn't have the questions before, but it's not a problem.
Right.
See, the best time, the question is best time for NT. So I would actually prefer that if this patients had an earlier scan. Usually nowadays, people generally do a scan in the first trimester for the dating scan. Unless they have, history of ectopic pregnancy or they want, they are very crazy to quickly have a diagnosis, they do even much earlier. But dating scan, if you have, then you can actually time the NT scan because we have found so much difference between the LMP and the dating. Now, coming to the exact NT, see, we know that 11 weeks is the best time because it is more correlates with the time when there is increased nuchal translucency and the tricuspid and the nasal bone, everything. But because at the same time, we also have to see congenital malformations. And instead of calling the patient once at 11 weeks, once at 12 weeks, I prefer 12 weeks. 12 weeks is the preferred time, but any time between 11 to 13 plus 6 weeks is the recommended time. The problem with 13 weeks is that the baby is very big by then, and usually the baby has maintained a position. They usually becomes, in a standing position often. And so it is difficult to get the measurements of the nuchal translucency. So if you have a choice between 11 to 13 plus 6 weeks, 12 weeks is the better choice.
Ma'am has been the Chief Maternal Fetal Medicine, and she was Professor Unit Head, All India Institute of Medical Science, the biggest institute providing world-class care to all the expectant mothers. And she's been the past president and founder president Society of Fetal Medicine, past chairman Genetic and Fetal Medicine Committee. She has innumerable publications to her credit, International Journal 258, books edited 5, chapters in book, and so many lectures. She's been national, international faculty, and she has various awards from FOGSI, Dr. C.L. Javeri Award, Dr. C.S. Down Award, Medical Disorder Pregnancy, Dr. Amarnath Award. So, ma'am, it's been such a pleasure, and we in our subsequent webinars we would like to hear more from you, and we are really overwhelmed. So, next question to ma'am, Deepika ji.
No, it's okay. Closer.
So, ma'am, for youngsters, do you recommend? We will have third question, Deepika ji, first. So, do you recommend any courses for the youngsters to know the real fetal medicine, or are you providing any of the courses in your center?
See, youngsters, if you've been obstetricians learning,
Right.
I feel that all the medical colleges, they must train their PGs in doing ultrasound. I think all the medical colleges have ultrasound machines. The
Right.
obstetrician doing MD, MS should be able to do ultrasounds. And we actually in AIMS, we used to have them coming to the fetal medicine unit. We had this 2 days of, fetal medicine OT, 2 days OPD and 2 days main OT. But I don't know how it is in the others. So medical colleges doing MD-MS course, it is at that time that youngsters can learn how to do the NT scan, how to do the level 2 scan and the other scans, biophysical profile and all. Those who don't have that wonderful opportunity, they can always learn, but it's in fellowship programs. But the problem is there aren't too many. So we have Ashok was here, the ICOG fetal medicine, we have courses, 6 months courses, and usually there are not too many of them. I have one fellow with me at present because it's quite a difficult thing training, without much help, others. So this should be there. Then nowadays we also have the Fetal Medicine Foundation and other online courses where the student can, under the guidance of somebody senior, learn how to do these scans, and then they have to send them to the Fetal Medicine Foundation and get certified. But I think for general obstetricians, because of the increased, problems of medico-legal problems, you can hear them every day. It is better that for obstetricians, the NT scan especially and the level 2 scan. These are the two difficult ones, relatively difficult ones. They should be done by fetal medicine specialists, whereas the other things like growth, Doppler can be done by trained obstetricians. I hope this answers your question.
Yes, ma'am, certainly, ma'am. In our time, we didn't have ultrasound machines in the department, only radiology. Forget about the gynae department, but now this generation is really lucky to have all these amenities. And I think the HODs attending this webinar would take a clue from you. Thank you, ma'am. And we have our other panelists also, ma'am. We will take the expert comments from you. We have Dr. Shalu Gupta, Dr. Dipankar Banerjee, and Dr. Anita Kant, infertility specialist with us, Dr. Dipankar Banerjee, who has interest in reproductive endocrinology and is director IVF consultant, Ideal Fertility Center. And he's working in interventional sonography as well. We have Dr. Shalu Gupta, the most versatile and efficient Dr. Shalu Gupta. She is, we have Dr. Anita Kant, chairman and HOD Gynae department, Asian Institute of Medical Sciences, Faridabad. She's past president, Faridabad Menopause Society, and she's patron, Faridabad Society. And ma'am has got various publications. Dr. Shalu, as you see from the photo, she's always smiling, always supporting, and I feel one of the best person to answer the questions today. And she has that attitude for the patients which one treating infertility patient should have. And her areas of interest are poor ovarian reserve, recurrent implantation failure, and PCOS. She has presented papers and has multiple publications in various journals and books. And it's pleasure having such learned faculty for this webinar today. She's co-convener IFS SIG for poor ovarian reserve, and she was our joint secretary Haryana IFS chapter. So this question I put to Dr. Sonu. Can we have next Dr. Shalu? So Dr. Shalu, you feel that IVF should be offered to any patient on request?
So this comes like an ethical dilemma when the patient asks that I would like to go for an IVF just because I don't have time. So normally I tell them the pros and cons. What is the pros and what are the cons for going for the IVF? As long as the patient understands what are she going to go in for, and she is explaining that always a natural pregnancy or pregnancy which is attained by natural method is much better than the IVF pregnancy. But still, if the patient insists and that no, I understand all the pros and cons, then yes, sometimes I do offer the patient the IVF on the request. But making sure she understands what are the cons about not having the trying naturally the pregnancy. Nowadays, a lot of patients are coming that they do not have any time for their partners and they just want to go ahead with the, because they have a busy schedule of their office or something and they do not have much time to try the natural, and they do, then they start even thinking that my age is going very fast and I may not be able to have children in future the way I'm going. So those are the patients where we, after a lot of discussion, a thorough discussion, understanding what we are going into, then yes, we sometimes go with the offer them IVF because on the request. But
So
I prefer to deter them from doing that first.
Exactly. So that is your conscious decision that you take. So one more question from you, Dr. Shalu. That patient has been referred to you all prepared for IVF. So do you straight away proceed, or do you look back at things where you feel that?
No, I do not straight away proceed to the patients for IVF because there are at least 25 to 30% patients where we are able to find a cause.
Exactly.
And these patients have conceived by simple ovulation inductions or by simple IUIs. And even if we tell them what has to be done, there are so many patients who come, they do not even know what is the fertile period. They have been trying just immediately after periods. And
Right.
when the fertile period comes, they are not at all trying. So we need to understand the history to find of the cause, because even our IVF will fail if we do not know the exact cause why they are not conceiving. So if we can find out the exact cause why they are not conceiving, then only, and in case we can, if we can help them to change the problem, or we can help them, then still they're not conceiving, then they should be taken into the IVF, as likely what you had also said in your lecture, that we should always look into the patient, look into the history, not just go blindly and take up the patient.
Very right, Dr. Shalu. That is what I wanted, because most of the times we have to know the cause, treat the cause, and patient conceives. Deepika ma'am, can we have your inputs on this, because you have been attached to such a big institute for such a long time? So
Yeah, see, when I was doing a lot of gynae, we used to do infertility. Everyone were doing, and we definitely spent more time in doing the initial workup. You know, we did, as who was saying, that we used to see a lot of cases of tuberculosis. You were saying. So we used to do the endometrial biopsy, the histosalpingogram, laparoscopy in that stepwise manner. And most of the times patients would just conceive on their own. And then of course, a few of them would need ovulation inductions and all. Very few patients were actually offered IVF.
So, Dr. Shalu, how many cycles of IUI you will take? I mean, if at all indicated, before putting your patient to IVF, like how we put it straightway, how many maximum cycles in any infertility patient you have done of IUI? Is there a limit?
Sorry, I normally go with 3 cycles, but if the patient insists, then maybe a 4th cycle, because they say the maximum of the patients will become pregnant with 3 cycles. So once if my 3 cycles are not, patient are not conceiving with 3 cycles, then I have a discussion with the patient, understand, they also understand what is happening, because I am very, what do you call, conservative when I'm doing my IUIs, because I like to monitor my patients very thoroughly during my IUI cycles to make sure that what we are doing is absolutely right. So the timing and everything of when we are doing the ovulation, when we are, the patient is ovulating, and when we are doing IUI, so that is very judiciously I follow to do it at the time of the ovulation. So 3 cycles, she's not conceiving. For the 4th cycle, we have a discussion, should we or should we not? Only if the patient says, no, yes, I would like to take, then only, otherwise then we move forward, start planning for the IVF.
Right, because most of our patients are poor and they can't afford IVF. So we have a good experience with long IUI cycles also, 6 cycles, 8 cycles also. And they have conceived in the end. We give up in our heart, we have given up, but they are really conceiving. So ma'am, Deepika ma'am, you will share your experience.
Yeah, we as a routine, you know, in names, we used to do them 6 cycles.
Right.
And then only. And of course, we always used to do the workup, including the laparoscopy before even starting ovulation induction. See, because infections, pelvic infections and tuberculosis is so common. So it's always better to directly look at the tubes, do the diagnostic laparoscopy before we start ovulation induction. Many times I see that people have started ovulation and afterwards you find that the tubes are blocked.
Right, right.
So yes, that's what we used to do. 6 cycles minimum. Huh.
Right. Thank you, ma'am. Dipankar sir. Okay, so we can have next question. That will be Dr. Ashok sir is there. Deepika ji.
I think he's left.
Okay,
Yeah.
so Deepika ma'am will answer this question for us and Shalu can give her inputs. So my question was, ma'am, what are the other treatment we are giving to patient of cholestasis? Like we heard everything, but we did. Oh, Dr. Dipankar sir.
Yes.
Sir, you tell us how many cycles of IUI?
Maximum 3 cycles, what has been described.
Right,
But
sir.
most of the time, IUI normally have been done previously. So most of the time they land into IVF and they come to me. So this is the most common scenario, but definitely IUI is an option if there is an so-called unexplained infertility and everything is okay. But personally, when IUI doesn't happen, then we should not push too much on IUIs. And we have to see the fallopian tubes in HSG because HSG is one of the very important investigation and should give the idea of the tube.
So donor cycle also is just 3. Donor cycle.
Yes, 3.
Okay. Sir, the next question was like patient has been referred to you for IVF. So how do you proceed straight away take up for IVF because that has been requested by the referring doctor and
Question is to me.
Question is to you, sir. We have already discussed because you were just logging in. So when a patient, our debate today was that the patient is now they're demanding too early IVF, and doctors also referring for IVF for certain reasons, certain indicated, certain unindicated. So do you straight away go or you do your homework again and then proceed?
Most of the time, what Deepika madam has very correctly pointed out that there should be a very good assessment. And that assessment cycle is very important and there should be an involvement of the male and the female. And most of the time, what is happening inside, we have to know, then only we can customize the treatment. Otherwise, definitely, I am basically a pro IVF person because I am very much concerned about the patient's age. If IUI, too many IUIs makes the patient little bit more older and AMH goes down, then chances of getting pregnancy with the self-X will be very difficult.
So Dr. Mittal, as Dr. Dipankar said, that age is very important. So, you know, we have to curtail, we have to modify according to the age. Certainly the patients and affordability. So if they cannot afford IVF, then we go on trying, you know, the little lesser in costly methods of treatment.
So any other drugs, Deepika ma'am, you will suggest management of cholestasis in pregnancy from your experience?
No, I think he has properly, actually, he's done everything like he's mentioned.
And some local application like we say.
Of course, local applications are quite useful. You know,
we talked about that. Yes.
Yeah. So calamine lotion is very, very useful. Not only that, some of them are very, you know, it helps them to take anti-allergic drugs as well.
Right, ma'am. So we all agree to be used at 36 weeks?
Yes, yes, yes. Because, you know, sudden, very unexpected deaths can occur. So depending upon if it is only, you know, there is no IUGR and the only problem is IHPC, then we can go up to 36, 37 weeks. But sometimes if there are other factors also, and depends on the patient's itching and the biophysical profile, though it can be normal, it can be abnormal as well. So it would depend upon all other factors. But if everything else is okay, then we can very cautiously, the 36 to 37 weeks, depends on your clinical acumen.
Ma'am, I feel that nature gives a call and these patients who are like to develop complications, they start getting contractions little early, around 34, 35 weeks, mild pains and then off and on. And then I think that's the time we should interrupt and go on. So anything anybody would like to add before we conclude, Dr. Shalu, Dr. Dipankar, Dr. Deepika?
Yeah, as you said, you see, meconium is a very important complication. So if you're allowing a vaginal delivery, you should induce by doing rupture of membranes rather
Right.
than,
Waiting
the
for long.
oxytocin. Yes.
Right. Thank you, ma'am. And this is the last question which we have already talked, that how many cycles in a poor male factors, or say azoospermic males, how is it 3 cycles again, Dr. Shalu, or we can go further?
Dr. Seema, the thing is ki now these semen analysis, if it's a donor sperm cycle, if we are taking, so they are providing us with just 3 semen sample, and the cost of the 3 semen sample is also coming out to be very high. They are charging here in Gurgaon almost 25,000 to 30,000 for 3 semen samples.
Right.
So again, putting 3 semen samples and then again going for another cycle of 30,000. So which is almost coming like to go instead. So if you're spending that kind of money, why not go with the IVF cycle directly? So when 3 semen sample comes, I am now right now talking to them that maybe 2 cycles of IUI you conceive well and good, conserve the 3rd one, and maybe if you like to go with the IVF, or you like to prefer to go with more IUI samples procuring, because after that ART law which has come up, to get the semen sample is becoming little tough, and the cost of the semen, the sperms has also gone up. So we need to understand the money issue, the logistics for the patients, what it is going and how it is going. I do not know what's happening in Rewari, how much are they charging. So it all depends upon the financial states of the patient, what they want to go. But yes, if the patient is not able to afford IVF and they want to go with the sperms, speaking to them and making them understand this, then it's fine. Because each IUI donor cycle almost costs them 20,000 to 25,000 rupees.
Right. So, Dipankar sir, any inputs?
This is a very, very pertinent point she has put, that the getting semen sample nowadays is costly. And personally, to be very frank with you, I try to be as far as possible non-donor, because I do a lot of andrology workup also, and I do a lot of 1/3 of my IVF cases mostly are on testicular sperm aspiration. And it is, if we go with the donor sperm, with the definitely IUI, personally I am pro IVF, because if you lose those cycles with that cost, things will be definitely very difficult to understand and withstand that problem with the patient, because there are a lot of questions comes why it is not happening and all.
Thank you so much, sir. So, do we have any questions from the audience here?
I have a question, because I see so many IVF experts here. This is a case that I faced today. So PGT and for aneuploidies, because most of the women nowadays are above 40 even. So are you offering it as a routine?
No,
yes, ma'am. For the patients who are more than 40 years of age, 40 and more than 40, I do offer them, because of the risk factor, they need to understand. Because in case they conceive and the baby comes out to be the Down syndrome, so they will ask us, why did you not offer? So as a clinician, it is my job to offer them the PGTA testing, and it is up to them whether they would like to take or they don't want to take. And so I do offer all my patients more than 40 and for more than 40, the PGTA.
Right. And you do take it from the embryo, or you take the fluid? Now that we have analysis?
Ma'am, still we are doing from the biopsy, from the trophectoderm, not taking the fluid, because fluid thing is still in the very start. It is still in the not experimental, it is very in the very still in the research, in the very early stage. For one of my patients, I did the PGT, and even I sent the fluid. In the fluid, only 2 of the embryos came out to be normal, whereas in the biopsy, when we did a trophectoderm, almost 4 came out to be positive. So it's in a very nascent stage, the fluid thing, and it's still not very standardized.
Okay, so actually somebody told me that nowadays you don't have to take the... Today I got actually a patient who was 41 years old, and she had, the upper limbs, only the humerus and the femurs were short. So I was wondering whether taking a biopsy can cause limb reduction deformities.
Ma'am, it is from the trophectoderm, so it's from the placental tissue, so it will not
Yeah,
be from the
it will
inner
not-
cell.
yes.
So
No,
it will
because,
not
you know,
go.
when we do CVS also, it's only in the placenta, but because it disrupts the blood flow, you know, you sometimes, the first thing that you got was limb reduction. So of course, I was planning to read up, but, you know, so many of you are there. So I was just wondering.
So no, ma'am.
Thank
it
you very
doesn't
much,
exist.
Madam Deepika. You took a very fine, very nice
Question.
the problem you have taken, and बहुत अच्छा, but I liked it because the thing is, personally, I am not very much pro biopsy person, and I offer nowadays as NIPGT, and there are two schools of thought for trophectoderm biopsy. Even at today, you cannot say that by trophectoderm biopsy you know absolutely about the inner cell mass that makes the baby. And regarding your point, that is a very, very valid point, because you cannot do Korean villus biopsy, should not do before 8 or 9 or 10 weeks.
10 weeks.
And we are handling with the trophectoderm in the nascent stage, in the early stage. And these things definitely comes in my mind also. Why should I touch this embryo if it is possible that I can get a cell-free DNA from the spent media? Then there are reports from the Spanish people, that is Carmen Rubio and another lady, that they have come with the concordance with the inner cell mass and with the trophectoderm biopsy, and this concordance has come near about to 86 to 89% with the spent medium. So what nowadays I am doing is not doing the PGT by biopsy, it is by NIPGT. And this NIPGT, if you are doing ICSI, there will not be any cell from the other part of the body, from the mother, no coronal cells. So it is absolutely an embryo, and we do NIPGT nowadays, not doing embryo biopsy, because this embryo biopsy procedure has, if you go with the literature, still the international society didn't come with the foolproof method that it is an effective method. And one of the very important concern about from my side doing IVF in 35-40 years lady who is already producing very less eggs. I have a lot of phone calls coming as I tell you that there are multiple cycle. One patient from Hyderabad, there are 4 cycles rejected, even though morphologically good quality blastocyst, because there was the problem is when I do NIPGT, when I do NIPS, like non-invasive prenatal screening in first trimester, we never take any decision by that without doing an invasive diagnosis. In the same way, here also we are taking trophectoderm, which makes the placenta. And if there is some problem like complex aneuploidy or aneuploidy, we just reject the inner cell mass without knowing exactly the diagnosis. If we cannot do with the NIPS during prenatal test, by taking that call that you should terminate or take decision even before undergoing, at least what I do an amniocentesis most of the time, you cannot make a final call by NIPS. It should not be called NIPT. In the same way, my point is, how can we take a trophectoderm biopsy being a representative sample of inner cell mass, which makes the baby without doing any diagnostic procedure and throwing away that morphologically good looking embryo.
Because nowadays I'm getting more and more cases where I have to advise, you know, they do not like to have CVSs repeatedly, especially chromosomal problems in the parents. And so.
Thank you, ma'am.
For making pre-implantation genetic test for Mendelian disorder, because it is a genetic disorder, so it will be available, it will be present in trophectoderm and here also. So for that, I feel that PGTM is a great boon for pre-implantation diagnosis for Mendelian disorders. But in spite of that, getting that embryo disease-free, or when we implant, we have to do a Korean villus sampling to confirm that disease, whether it is disease-free or not. So
the PGT will only help you to choose a better embryo.
Better embryo. Thus, the chances of rejecting the pregnancy will be less. Thank you very much for giving me this opportunity.
Nice to meet you after a long time,
and
Dr.
Madam Deepika, thank you very
All
Yes,
these are
Nice to
becoming
see
our
you.
darling.
बहुत अच्छा लगा.
नहीं, मुझे भी बहुत अच्छा लगा. And Shalu, nice to see you after a long time.
Same.
After
Yes,
a long
ma'am.
time,
Same here.
Thank you.
we went Sydney with
Thank you
for
so
ICU.
much, ma'am. And
Thank
thank
you.
you, Dr. Dipankar. It was really nice to be listening to you all. So many good things we have learned. It was literally like filling up the lacuna. That's the topic, but the session
Thank
you
you,
planned,
madam.
Dr. Seema, it was really good.
Thank you,
Everything
thank you.
from
Mhm.
first trimester scanning and how do you go for that infertility part also, everything very, very nice.
Because
Thank
because
you, ma'am,
what is
Deepika.
what
Thank
is
you,
hap-
Dr. Dipankar.
Thank you.
Hanji,
Thank you.
sir.
Sir, you're saying
Ma'am,
something?
ye both, I want to sum up this because the way I do the practice, what is happening nowadays, we are channelizing ourselves to either fetal medicine or a reproductive medicine, or because what I feel that it is a spectrum from where the life starts. What I do is, abhi jo main fetus con kara raha hu, I kept a topic that from prenatal to preconception genetics.
Yes.
Because until unless you know the reproductive medicine genetics, then only you can apply this thing in your obstetric practice in early pregnancy detection of genetic disorder. Otherwise, if we are segregating the thing from prenatal test koi aur karega, reproductive medicine koi aur karega. If you cannot join those dots, then there are
Yes.
many cases coming to me. 3 से 4 बार 5 बार IVF repeat हो रहा है. I feel very sad. What happens if you tell a lady कि आपका embryo, your embryo is not good, aneuploid or something? Definitely there will be, but if it is morphologically good, अभी तक time lapse आया, इसके बाद embryo biopsy आया. You know this embryo biopsy, trophobacterium biopsy is detrimental. That's why this NIPGT came.
Right.
Because second, NIPGT came with little part of the inner cell mass, cell-free DNA coming into the spent blastocyst media, spent media. So at least we can get some part of the inner cell mass which is coming from the cell-free DNA from inner cell mass along with the trophobacterium. So there will be more representation. But in spite of that, if there is a good morphology, if there is a good blastocyst of IA, if it started hatching, then I personally, even though it is 41 years, 40 years, I tell them get pregnant. I will do your prenatal test as far as possible to identify the aneuploidies. But at least get pregnant. 3-4 cycle हो जाते हैं, उसके बाद भी एक भी embryo transfer नहीं होता. It is very painful sometimes with good morphology. I think I am little bit controversial, but sorry to say that.
You are always
We
out
have to
of
know
What
because
is there
patients
actually?
are more, demanding.
master and jack of all, sir. You're exceptional.
No,
Not only
there is such a lot of difference from government hospital and private. Now
Yes.
that I'm in the private, I have to think of many other things which I never thought about in AIMS.
Right.
Yeah.
So,
Even
what
not
Dr.
only demanding, but the need of the present scenario, because with the type of lifestyle we are living, the patients are living less time for themselves. And then what we have discussed earlier also, that is the problem. So they need to be brought under only one person to, from that preconception to the conception and then postnatal, everything has to be taken
And
care.
technology changing
very
every
important.
second.
Yeah,
So,
yeah,
to
that
Dr.
is
Alka
there.
to
Yes.
thank all our esteemed faculty today. Dr. Alka, our President Rewari Society, to thank Dr. Dipankar. And Dipankar sir ka conference, sir, I am not able to join, but everybody should join because we will have so much to gain from him. Deepika ma'am,
Pre-fetus con cardiology workshop भी हो रहा है, fetal cardiology workshop. Deepika madam, मैं आपको देख के एकदम लगा कि मैं आपको faculty बना लूं तुरंत.
So over to Dr. Alka to thank faculty.
Now, I'd like to thank our esteemed faculty, Deepika ma'am, Dr. Dipankar, Dr. Shalu, and Dr. Seema, of course. Then Dr. Bela Bhatt was there. She was very nice with all the first trimester screening. And I'd like to thank Jagsonpal also for providing this platform and such a good academic session. It was really nice. Thank you, Dr. Seema, again. Do keep on doing such sessions.
Thank
you,
good
Seema.
leader, you're motivated.
Thank you, Seema. You are continuously making this thing. I really admire that. बहुत
Thank you,
effort
sir.
लगते हैं इसमें.
It's just,
Thank you.
just to have a look of you. I mean, there's a reason for holding this webinar. At least you come here and you talk to us, sir. And
Alright,
Deepika
thank you
ma'am,
very
it was like icing on the cake. And Deepika ji, all these are becoming such darlings for us. So Dipankar sir, Deepika ma'am, Deepika doctor,
D. All
Dr. Sunil Takyar sir, everybody has spent so much time for us. Anubhuti, your favorite, your such beautiful secretary, Dr. Alka secretary, everybody has contributed. And it was a wonderful
Okay.
discussion. Thank you, Shalu.
Thank you.
And
Thank
we really
you.
enjoyed.
Nice to meet
Bye-bye.
everybody. Bye.
Thank
Bye.
you. Thank you.
I'd like to take this opportunity and thank everybody, Jagsonpal, the progestin people, truly, because we have all the progestins that are required in your practice. Divagest is our natural progesterone range. We have SR tablets in 200 and 300 mg strengths. Then we have vaginal soft gels, that is Divagest 200 mg and 100 mg injections of Divagest available. We have dydrogesterone 10 mg tablets as Divatrone. Hydroxyprogesterone caproate, our age-old Maintane injections, 500 and 250. Also the Maintane tablet, that is Elastostanol 5 mg. Then our other progesterones, which are progestins available, are Cyclorex CR10, that is norethistron in controlled release form. Then plain 5 mg norethistron tablet as Cyclorex tablet, and Dynogest 2 mg tablets as Endorex. So we look forward to your support to the progestin people, truly, Jagsonpal.
Thank you, Deepika ji. Thank you so much. Thank you,
We
Deepika
will see
ma'am.
you again. Thank you all.